Hello and welcome to the Digital Health Hubcast, where technology and healthcare collide. I'm your host Hannah Clemmens from the South Yorkshire Digital Health Hub, where we're on a mission to tackle health inequalities by transforming the future of digital health. Digital innovation is at the heart of the future of healthcare. And on this podcast, I sit down with leading experts and innovators from across the digital health landscape to discuss the biggest opportunities, toughest challenges, and how we can innovate in this space to create a healthier and more connected future. Today, we're diving into a space that has long been underfunded, underserved, and overlooked: women's health technology. Femtech encompasses apps, products, and services designed to support the health and wellness of anyone born female, and is a rapidly growing market. From period tracking apps to diagnostic tampons, the femtech sector has exploded over the last 10 years. Despite growing popularity, challenges remain. Women are still substantially underrepresented in research, and women's health is often viewed as a niche issue, despite women and girls making up just over half the population in the UK. With the gaps in research, issues of access and equity, how do we build truly inclusive, ethical, and data-responsible solutions that serve everyone affected by women's health issues? To help tackle some of these questions, I'm joined by Dr. Becky Mawson. Becky is a GP, women's health researcher, and digital health innovator interested in addressing inequalities in sexual and reproductive health. Oh, Dr. Becky, thanks so much for being here. How are you doing today?
Oh, it's great to be here. I'm so excited to be in your little podcast booth having a bit of a record.
It's very cosy in here, yeah. Yeah, we're here today. We're going to have a natter around women's health technologies. So I'd love to know a little bit more from you initially. What drew you to women's health in particular?
Oh, gosh. So interestingly, considering we're talking about technology, I'm not someone that comes from a world of technology. So I came really into women's health. I always enjoyed women's health and obs and gynae at medical school, and got drawn into reproductive health. I initially did obs and gynae training, so obstetrics and gynecology training, and was just fascinated by the female body, and that sort of led me on to this lifelong really specialty development around women's health. So I went into general practice because labour ward absolutely terrified me at the hospital. Delivering babies was probably the most scariest thing I've ever done in my entire life. So I decided that obstetrics wasn't particularly for me, and so went into general practice, where I've now developed pretty much a specialty just doing reproductive health and women's health and a bit of sexual health. So that kind of drew me into women's health. And then as the more I've done in the world of women's health, and I work a lot within underserved population groups, I suddenly realised that actually probably going down the technology route is the way to kind of improve health equity when it comes to women's health. So that was kind of the long route in that's been over the last 20 years of development. But it's just an area that I feel has been so neglected over time, and I think in some ways, especially at medical school, we're very much taught this model that sort of manifests around the male body. And I think I was so amazed and bewildered that suddenly, we always thought of the female body as just being like a smaller version of the male body, like a sort of default, subtype of the male body. And then suddenly as I left medical school and got more into women's health and gynecology, I was like, oh my goodness, the female body is so different in every single way, shape or form, in terms of physiology, immunology, all the different ways that our bodies are different. But yet it seemed like a crazy mystery. We still know pretty much as little as I did when I left medical school, about women's health. So for me, I think the area is almost a bit of a mystery that I feel like it needs to be understood better. So I think that's the kind of reasons that I really went into women's health, and I'm still so passionate about it, that I'm very happy with where I am now.
Yeah. Oh, that's amazing. Yeah. I suppose I was going to ask, why do you think it's been so underserved? I suppose one of the answers to that is probably patriarchy.
Yeah. Yeah. And I always worry, because I think sometimes it's easy for I don't want that men that are listening to switch off and be like, oh God, another one whining, another woman whinging about the patriarchy, which I totally understand. And I have male friends who are like, oh goodness, we always get the blame for everything. But actually, it's not it's not men in particular. It's the fact that medicine, politics, society has been very male dominant, since the beginning of time. Science was very driven by men, and women have always been kind of sort of in the background with it. And so it would be completely understandable that medicine in particular would be driven to look mainly at the male body, and women's health conditions seen as very much like a sort of awkward side effect. There's a fantastic book by Elinor Cleghorn. My brain always forgets, but it's called Unwell Woman, and it's probably one of my favourite books I've ever sort of read. And she basically gives a history of medicine since the beginning of time, when they used to talk in the Greek times about a thing called a wandering womb, and your wandering womb was your womb moved around your body, and it was responsible for all of these different ailments that women were afflicted by. So it would wander up into your lungs and make you short of breath, and it would sort of wander up towards your brain and make you have seizures. All these things. That's how they kind of explained it, that there was this sort of weird organ in this this male subtype's body that was then causing all of these issues. And actually, in reality, it probably was like the fact that our bodies, the female body is made to carry a foreign body for 9 months. It is completely different to the male body, because it has to be able to adapt to having foreign DNA within it and grow it, and that's why, we see so much more autoimmune diseases in women, this completely different immune system. But yeah, so if you've got a sort of, it's kind of completely understandable that we would have this sort of model of care which is very much sort of led by this idea of the male 70 kilogram body, and I think what that's meant is that we don't see like you don't see how diseases are impacted by being female, and we never learnt at medical school about so why people might have different reactions, different medications. There's I know I talk about this quite a lot, but it wasn't until the 90s that women were encouraged to be in clinical trials. So a lot of the drugs that were invented before the 90s were never tested on the female body. And so what that's meant is that we have this sort of almost inequality in data, because we don't really know how different drugs and different health conditions might affect the female form differently to the male form. And I think that for me is like the biggest mystery that I hope we in the next 50 years will be uncovered. Should we be treating diseases differently between different genders? Should we be I shouldn't use the term gender, I try and use the term sex rather than gender, because I think gender is about how you feel and how you live, whereas sex is more to do with the kind of biology. But I think will there be a time that we sort of think more about how our hormones, especially estrogen and other drivers within the female body, how are they impacting on different health conditions? So yeah, I can't even remember what the original question was, but I've just gone on a massive tangent. Was it about the patriarchy? You can always get me talking about like going off on tangents, but it's not about blame. It's just about like a recognition. And I think I wish if I could go into medical schools, I'd be like, there are physiologically differences between the male and female bodies. Can we start thinking about how we can harness that, and how we can have more effective treatments that kind of harness that differences? And can we understand diseases more by understanding some of those variations? And just going back to clinical trials. So one of the reasons why drug companies in particular don't like using reproductive age females in their studies is because we have hormonal variation, which might then affect the power of their sort of outcome of their drug. And that just blows my mind that they want like postmenopausal women, or they want people male participants. And I'm like, if we're excluding people because they have a hormonal cycle, then how are we capturing data about how these drugs vary through a cycle, and so it's just it blows me away that we don't have that deeper understanding of how different drugs work for different hormones, parts of the cycle. There's so many reasons why we're sort of underrepresented when it comes to sort of healthcare and sort of science. But I mean, the good news is it's changing. Like we're seeing more and more we're seeing more and more women in sort of powers of where they can decide where health gets funded, and policymakers. So I do think obviously it's changing, and there's more with the women's health strategy, there's more kind of awareness of it. But yeah, it just still blows my mind that I never learned that there was any difference between men and women, and it just that to me is crazy when we think about it. So
it really is. And I think, you know, when I was learning about drugs and things at university, and then I learned that women weren't included, I thought, well, if women are taking the drugs, then why aren't they in the studies? So I suppose what's the way forward with that? Are women now being included in these studies, or is there something different?
Yeah, I mean, it's a similar argument that we see with some underrepresentation of ethnic minorities in drug trials. Like, you know, I think there has traditionally been so people conducting different trials have almost cherry-picked who went into the trials. So understandably, if you've got pressure on you as a project investigator to recruit a set number of people, you go for the easier targets because you know, if you can send you know, for example, I was involved in a vaccine trial in Sheffield where we were trying to recruit people onto our vaccine trial from different GP practices, and we'd send a text out from the GP practice to different participants who were eligible, and then they'd contact us and be enrolled in the vaccine trial if they wanted to be. And we purposely did it almost like a bit of a tester to show like the differences between different areas of deprivation. So we had a very affluent area of Sheffield, we had the most deprived part of Sheffield, and then we had my practice, which is kind of in the middle. And it was exactly as expected. You know, we had really good recruitment from the affluent practice. We had hardly anyone from the deprived practice, and sort of middle numbers from ours. And you know, we talked about it a lot because we wanted to use it as like an example for why it's much easier to recruit certain groups, and it was, you know, all down to, you know, the participant information leaflets, for example, really, really long, very scientifically worded. Even the text that we were sending out, which had been agreed by the vaccine company, was quite complex and difficult to read. You know, you had to click on a link, then took you to another link, to then, you know, so there are all these sort of issues that we put in the way of people to in terms of getting them recruited. And so it's understandable that if you fill your trials with people who are the first respondents, easy to group, you will get, like, you know, affluent areas, often men, you know, because you know, you're trying to target people who aren't sort of in the reproductive groups. So we have this, you know, this real challenge. And so I think the way around it is that we really need to change how we you know, as a you know, I'm talking across the NHS and wider, we shouldn't be adopting either, whether it be new technology, and you know, I can talk for hours about, you know, technology and inequalities, but we shouldn't be taking new technologies or new you know, interventions or drugs that haven't been tested across a wide span of people. Now, you still don't have to publish in the UK your ethnicity data. Like the NIH, so the National Institute of Health in America, have brought in regulations that you have to publish your ethnicity data, and with that you have to have a breakdown of gender. Although with the political landscape, it's difficult to see what's happening there. But so what we need is that transparency of what the drugs. So I know, especially as a GP, this drug has been tested on my population group. You know, and that is so key for us to try and equal the playing fields. Otherwise, we're using interventions and we're using drugs that haven't been tested on the population groups. So you can't honestly, hand on heart, say to a person, you take this drug and you're going to have, you know, this much better improvements in the risk of heart attacks in the next 10 years. But that's what we do. We tell people, oh yeah, you're going to have, you know, for example, you know, if you're a woman and you're black, you probably had the least amount of drugs tested. So we're telling you a drug, you know, counselling you about using a drug that might have been tested on white men, and so it's that's huge when it comes to you know, it's the huge need is around like transparency when it comes to what we're testing and how we're doing it, which I definitely don't think we're anywhere near as we are now. But yeah, it's a difficult one.
Yeah. You mentioned right at the start that you were kind of moving into technology as a way to support more people. I was wondering if you could speak a little bit more about the kind of current landscape of women's health technology, or Femtech, if you want to use that.
Yeah, Femtech.
Yeah.
Which is a new catchy word.
Yeah.
And I always laugh because it makes me feel like everyone talks about Femtech and it's this massive like growing field. There's like millions and billions and trillions of like ghost market. But actually when you break it down, like I think, you know, Femtech, so female specific technology, only accounts for about 1 to 2% of the general health market, which is nuts. Like, if you read the like social media and you read the, you know, the sort of press, it would be sort of saying, oh, you know, Femtech is this massive growing market, and yes, it is, and it has seen considerable growth, and I'm really passionate because I feel like, and this comes from, it's backed up by the WHO, who did a brilliant report about technology into the women's health landscape, in the fact that it has such amazing potential to level the playing field. So if we can really develop systems that can break down all those barriers of like geography, education, access to specialist care, if we can break all those down by using technology, we have this amazing potential tool at sort of breaking down some of these like pretty awful disparities we see when it comes to women's health, and that's sort of globally as well as in the UK. We see a complete postcode lottery across the UK. So where you live affects, whether you, like, for example, I see it all the time. My research sort of outside the tech world is around endometriosis diagnosis and access, and we hear stories like over and over again about these women taking 7 to 11 years to get a diagnosis for endometriosis. And and it completely depends on where you live. Are you near one of the really specialist centres who does this incredible surgery, or are you near a general hospital that does, I would count, substandard like surgery for endometriosis? And should you even be having surgery anyway? Shouldn't we be diagnosing in different ways? So depending on where you live, depending on what how good your GP is, impacts what you can access in terms of healthcare. So for me, if we can develop really, really good sustainable models that kind of link all that together, I think that's for me where we could really do some incredible work at reducing inequalities. What I feel a little bit at the moment is that the Femtech world has become, there are, like, don't get me wrong, there's some incredible companies that are doing some absolutely fantastic stuff. But I'm either seeing it so remotely, like I'm hearing these amazing different products coming through that are so far from reaching me on the front line. I don't think they'll ever reach the front line where I work, day in and day out with patient care. These technologies aren't coming through. They're staying very much, either they're in secondary care, so they're in, especially surgical technologies, those are developing. But the things that actually could help my patients on the front line aren't coming through. And as I say, I don't think they'll come through in my sort of career as a GP. But the other flip side of it is that what I worry about is that in the current landscape, we're almost like worsening some of the inequalities within reproductive health and within female health, because we're seeing a massive boom. People are realizing that there is money to be made in the world of female technologies, but it's being very driven by money and monetization of women and those born female, and that's what I find very frightening. A lot of the technologies we're seeing coming through are targeting affluent, tech savvy, developed world people, and almost like mining wealth from them, and I fear that the way that we're going with the current technologies is they're just becoming more and more further away from what we need actually when it comes to the front lines of women's health and reproductive health. So I guess that's I feel like excited because I think there is so much potential, but I also feel do we need this like new technology that's going to be for the wealthy? And I think that's that kind of one of the things that does worry me a little bit. I've spoken about it earlier about the sort of the lack of diversity in tech companies. Like we don't see a lot of diversity when it comes to the tech companies and those who are sat around making the decisions, but we also don't see a lot of diversity in terms of who's testing the products. If I don't really care if your product can work for someone who looks like me, white, privileged, affluent, I'm already doing fine. What I want to see is it working for those who, might have a disability, might be neurodiverse, might not have English as a first language, all the cultural things that come with different diverse groups. I want to see your product working for those groups. And it's the same with drugs. I want to see your drug working for those groups. And if you can prove to me that your product is acceptable and it does a great job for all diverse populations, then I will accept it and I'll give it to my patients tomorrow. But I'm not seeing that. Like I'm seeing, I guess it's a bit of an echo chamber, isn't it? Like if you've got the same people around the table, then it's an echo chamber of the same thing. And sometimes I see these products and I'm like, I'm pretty sure someone has just put into chat GPT, how can I monetize Femtech? Give me a product, and then it's spewed out as a product, and I'm like, oh my God, this is literally not going to make any impact on the people that I see day in, day out. So I think there's so much potential, but I'm also a bit, I would like to see better diversity. And the other thing that I think is really alarming is how hard it is as a female innovator, to get investment. I hear stories, I hear stories of many innovators and founders who just cannot get funding, whereas their male, similar people to them are getting funding, and I think that's really shocking that we can't even fund women in the in the femtech space. So I mean, I really, if I see another kind of white male founder being celebrated, it just makes me go, oh Lord, where's the diversity? Where is the kind of designing for the person that's going to be getting the product? But I mean that's just me, but I don't know if you feel the same with
completely. I mean, there was a Guardian article a few months ago that said exactly that. It said I don't remember the exact statistics, but the number of female founders who are just struggling again and again and again to get funding, and then you see, I think, is it the biggest femtech app is run by men currently? The biggest
two
one.
brothers. Absolutely. And it just like blows my mind. And I think the other thing that I think is really interesting that I've been reading a lot about is like censorship. And I think it's censorship or something. There's basically a movement that's been brought together by some of the female founders to be like, even when we do get a product, we can't advertise it because like Google, Amazon, they just take away your your, like if you put vulva or vagina or whatever in it, then you're lost. People having to write sex as S3X. I'm just like, I tried to upload a publication on LinkedIn the other day, and it was a publication that I wrote about sexual well-being for older patients, and it wouldn't let me put it up because it had the word sexual in it. So I had to put a 3 as the E, and I was like, oh my goodness, even I'm being censored trying to share my like academic work. And I was like, goodness me, like it's so interesting how the algorithms are also like pushing back against us using like correct terminology. It's almost, it feels like the machine is pushing back against those sort of technology developments within sort of the femtech space. And I think that for me is really, really frustrating. It's interesting. And sorry, just another thing that came to my mind is we're talking about like the lack of representation, like diverse representation of participants. So there's this huge push, isn't there, at the moment about like AI and large language models, and it seems to be like the sort of the thing that everyone wants to create is stuff for us. And I have to say, like, as a doctor, I need to know how things work before I recommend it. So that's like biggest piece of advice to people doing AI or large language models is I need to know why this is making a decision for my patient, because I'm not going to trust it unless I know. But if we're using, like, what really makes me worried, if we're using all the previous, historical data to create these large language models or AI, which is already completely biased because women weren't included in it, like where does that take us to? And that's a big worry for me, is that are we creating more inequalities by using such biased data models that we're and then we just believe them. We're like, oh yeah, I'm just going to trust this bit of AI that's been completely non representative sampling to create the model. And so that's a big worry for me. And I think that's something we need to talk about when anyone is developing some new piece of technology. I want to know who went into this model, like what is the data, what data went in here, so we know that when we're making a decision, that I'm making it based on my population group, not on the population group that were easy to sample. So I think that's kind of one of the big concerns with me. And it just popped into my head because I was just thinking about how we're worsening inequalities by what we're doing. And when you've got a whole population group who haven't been part of clinical research, we need to change like the rhetoric, and it needs to be a really important part of going forwards. And we say this all the time with clinical trials, outside the tech world, we really need to be thinking about this more, whether it be dementia, whether it be heart disease, talking about things that are completely non kind of femtech related, though we need to understand how those are affected by, you know, female gender. So or female sex, should I say. But yeah, it's just a thought that just popped into my head, that something that frustrates me.
Yeah, absolutely. Yeah, you're completely right. So it sounds like you're saying that transparency with anything is really important, whether it's a new drug, whether it's a new tool, AI, whatever it is. You need to know, how have you come to this product? You know, what data has been used, or what people has this been tested on?
Yeah, absolutely.
You're also saying that more diversity, you know, even amongst this landscape where that seems to be less important with the higher ups, but, you know, diversity at all levels, making sure that people from, you know, a wide range of backgrounds and experiences are involved in each part of the conversation.
Absolutely. And also develop with the front line, you know, like I think there's a real disjunct, like maybe it's because I work in primary care. I suspect in hospitals, you know, if you're a surgeon, I expect there's probably quite a lot of technology advancement because you're using products, you're kind of doing stuff. But because I'm completely patient facing, I feel like there's the technologies that are coming through are pretty rubbish. Mm-hmm. Like we get funded these apps and sleep apps and mood apps and all these different things. I'm thinking, like, these haven't been tested on my population group, you know, and I think I call for anyone that gets funding in the NHS to have a representative, just a report or something that says to get my technology funded in the NHS. This is how I've come to this product. Yeah. I mean, that, like, I don't see why that is, like, so difficult to do, but I think because people don't want to do representative sampling, people find it difficult. They use annoying terms like hard to reach, which I would try and imply is actually more just easier to ignore. It's easier to ignore these groups because they might have different needs for you to be able to have them, you know, have the conversations at the table. So I just, it's one of the things that really frustrates me, and I feel as a clinician that I don't want to be using products or technology that haven't got that, you know, but we don't really have any choice because they're just given to us by by our local funding commissioners. So I think it's the responsibility of, if you're commissioning NHS technology services, you have to get the company to show you how they've developed the product. Like, it doesn't, how is that a difficult thing to do? You know, these companies should be doing it. They should be saying, like, we've got everyone around the table. But I just feel very much like that doesn't happen. But I think it's really important that we talk about it, because I have a responsibility to my patients. I'm not offering them services that aren't going to help them. And I think it's unethical for me as a clinician to be offering, and I probably, you know, the drugs that I probably prescribe every day that don't have good clinical data, especially within the female space. So I think transparency is so key, but I do feel like everything seems to work and sort of cloak and dagger. Like, having dipped my toe into the sort of femtech world, it does feel like a bit cloak and dagger, and that's why I've always tried with all my products, like with my research, to put it all out in the public space, because it's not owned by me, it's owned by the people that take part in my research. So but it's a very, very weird space sometimes.
Let's talk a little bit about trust then. It seems to be all involved in transparency. So do you notice with, you know, new products coming through, are people really open to giving their data to these things and using these products, or do you feel there's a little bit of hesitancy or lack of trust at these new products coming through?
I mean, I guess so. My research outside the tech world is with underserved population groups. So in Sheffield, I work very much with minoritized groups, whether that be ethnic minorities, or it be I work with street sex workers or trans masculine community. You know, the communities that are kind of underrepresented in mainstream research. And I have to say, like, I don't feel like a lot of technologies are coming to them for a start. When it comes to apps, like, we have this discussion quite a lot about like period tracker apps, for example, within the groups I work in, and most of the women in my my public engagement group have an app, you know, a period tracker app. They don't use the big ones because of concern around, you know, how their data is being sold or farmed. I think is quite useful to thinking about. Like, I always encourage people when it comes to sharing their data, like, think about who's making money out of your data, and if you're happy with that, go for it. Like, you know, there's no, but just be aware that your data isn't being, they're not giving you the period tracker because out of the kindness of their hearts. They're not doing it because they want to give you a great journey. They're doing it because they're either selling your data to third parties, or they've got some subscriptions they're going to need to pay for it, or they're doing both. But I don't think it's easy to understand. I've signed up to loads and loads of different apps during sort of exploring app design, and when you log on in the front page, it's got kind of the legal text, and it's so long and it's so difficult to read that most people just, I myself just scan through it and say accept, because it's not written in a way that any of us can actually digest. Unless you're a lawyer, you can't understand it. And this isn't different actually from the clinical trials. You have to really question whether people are giving informed consent when they don't understand a piece of information you're giving them. Whereas a company's like, okay, what can I put in this text so I can cross all the T's and dot all the I's and make sure that I'm not going to be sued because I'm, sharing your data. And so basically you're giving people carte blanche to using your information as freely as they want to. But I have to say the groups I work with either just wouldn't use an app because they don't trust it, because it's a sensitive area, we're talking about reproductive health, it's a sensitive area, so just wouldn't use it, or the flip side is they don't think about it and they just use it, so there doesn't seem to be, I think, because we're not having these conversations as much as we maybe should be having, it just kind of it doesn't necessarily fit, but I think there are some really clever things that are coming through from some of the femtech innovators in terms of design by privacy by design. So thinking about there are companies out there who are really prioritizing this and trying to only collect the data that they need for to be able to do what they need to do, or they're thinking about different monetization routes. So they're thinking about different ways to make money that doesn't mean farming your data. But I do feel really, really uncomfortable with the concept that you create a really good app and then get people to put all their information into it, tracking loads of very personal reproductive health things, and then that data then getting used by a third party, or to then fund insights to third parties. We know all the challenges with algorithms and the way that our world is being driven down different algorithms through social media. We really have to think about that we own our own data. I think it's quite different when you're part of a research project, because we have such strict privacy. When you're part of a research project, you have to go through lots of ethics, and you have real strict data management plans about how you control people's data. I never would ever dream of sharing any of that data outside of our research project. Sometimes we have anonymized databases that can give us insights into different health conditions, but it just blows my mind that people can make so much money out of farming people's insights. But I guess that's the way of the world. But yeah, I think anything, because we're talking the stuff we're talking about in femtech is so sensitive. We can be talking about abortions or pregnancies, or when you're having sex, or who you're having sex with. For me, I would want that to be very much kept within my app on my phone, and there are some really cool innovators who are working out ways to do that, so that your information isn't shared up to the cloud or other places. And I think as more and more people raise concern about it, I'm hoping that's the way that I really want femtech to go down, that route of only getting people to disclose things that they need to disclose at that point, so that so we're not sort of getting data that we don't need, that we're just collecting because we might then be able to make some money out of it in the future by selling it to third party. And I think we really need to have an honest conversation about how we feel about that when it comes to our data. And so personally, I don't do any tracking because I don't want someone to know where I've been or what I've done or anything like that. So but obviously I'm particularly aware of it / paranoid.
Yeah, and I can understand it as well. I always think obviously I scroll past the thing, I'm like, I'm not going to read all of this, and then I'm always thinking, well, what is happening with my data? Where does it go? Who's going to be reading all of this? And it sounds like what you're saying going forward is a kind of shift from making these products to make money to making these products to serve people.
Yeah, 100%. And I think that's where, unfortunately, we're not on the right side of that balance at the moment. We're in a space where, because it's been so underfunded, there is a grapple and there's a power play at the moment. And that power play is like, how can we monetize this? And what I really, really hope, and I can definitely see like glimmers of light coming through, is how can we shift this conversation from how can I monetize this to how can I actually like dramatically change like the reproductive health landscape? And I see that in particular on a global scale, linking, mums with pregnant women with complex health conditions to a specialist that knows what to do. Like that revolutionizes things, like the Tommy's app. So Tommy's app has been developed with the team in Sheffield, and it's an app around like making sure that you have all of your antenatal screening that you should have, basically. So it sounds like a simple a simple thing, but what I've seen is like it has had a dramatic impact on making sure that people have the right things at the right times during their antenatal journey, because most people haven't done it before. If they've done it, it's a complete mystery, and they've actually shown initial data that that it actually improves access of underserved population groups as well to the right screening, having it when they need it, and for me that is so exciting.
Amazing,
and if we can do that on loads of different scales, whether it even be the journey for people with painful periods, life impacting menstrual problems. If we could develop something that then put them on a pathway, so it didn't matter if their GP was, didn't know what they were talking about. And I'm saying that as a GP, so I feel like I'm allowed to GP bash a bit, because there are a lot of incredible GPs out there and practice nurses, but there are some pretty poor ones who are not providing good like women's health. But if there was some way of like streamlining it, so people knew like, okay, so I've got this, okay, these are the potential conditions that this could be caused by. These are the things I could try initially. These are the investigations that we'd recommend. So everyone gets on this, like, so we're not waiting 11 years for someone to get an endometriosis diagnosis, like it kind of, I think it has so much potential, and that's why I'm so passionate about it. I think I'm almost a bit of an outsider in the tech world because I'm not a tech person. Like I didn't come into this field through technology. I came into it through health inequality work, and just the realization that actually we need to shift into technology and we can actually bring the two together. My work is all about public engagement, community engagement, driving research through communities, and I've suddenly realized that actually the best way to make the biggest impact is to use technology. And so this whole year of being part of the digital health hub cohort has just blown my mind when it comes to technology. And I still feel like I'm in reception class. I feel like I don't really know what I'm talking about, and I don't understand a lot of the sort of words. I'm constantly like Googling, what on earth does this mean? Yeah. But what's been great is like seeing other people in the space, and I guess it gives me a certain lens so I can look at it. I'm probably a bit more of a critical friend maybe in this space of like, well, this product's obviously not going to work because you haven't actually talked to people about it, And I can see that when I see some of these things coming through, on LinkedIn. I'm just like, oh my goodness, have they actually spoken to a woman about this device that you're wanting to shove up their, So yeah, I guess I'm a bit of a realist when it comes to this area. But I think it also means that I have got a good insight into like what's going to work and what's not going to work. But yeah, it's been it's definitely been a journey.
Oh, amazing, Becky. It's been so great to speak to you this afternoon.
Thank you for having me on.
I'm going to finish with one silly little question. If there is a myth or a misconception that you would want to bust about women's health or women's health technology, what would it be?
Oh my goodness. I think the most hilarious thing is when people come up with a technology that's a sort of a male-orientated technology, and then they make it pink, and they're like, "Oh, this is suddenly going to make it like this is going to make it a perfect femtech." Yeah, because girls love pink, and so let's just make it pink, and then it'll be perfect, like this Fitbit or this bit of technology. Let's just make it pink, and then that'll kind of that'll create something that'll do it. So yeah, that kind of annoys me quite a lot. I'm trying to think of other things I would like myth bust. I mean, it all really comes down to the fact that like there are two different physiologies going on between the male and female bodies. And so technology needs to be driven at those differences and understanding those differences better so that we can then develop technology, yes, maybe using other specialties, because one of the problems with women's health in general and Femtech is that it's so behind in the science because it's not been invested in, and it's still not being properly invested in. So we're basically practicing in the dark. Like sometimes I feel like when my passion is around early diagnosis of women's health conditions, like diagnosing them right at the beginning, but I feel like I'm working in the dark because I don't have good diagnostic techniques. For endometriosis, the gold standard is still a laparoscopy, which is surgery. Like, what are we doing? And there is some cool stuff coming, but it's still very much in the development phase. But yeah, I feel like create technology that's going to impact that. Don't be like just making it pink or kind of putting some like vulva signs on it or something like that people just get it wrong. So that would be my sort of big myth busters. You don't need to make it pink. Don't take some ink mail and make it pink to try and create the femtech world, and stop using ChatGPT to come up with women's health technologies. So talk to the front line, and that's kind of that'd be my biggest thing to bust.
Not just small men.
We're not just small men. In fact, I'd probably argue that I'm sometimes bigger than some men. So, but yeah, no, we're not just smaller versions. We're not just subtypes. We're different. So, yeah. So I hope that's helpful.
Oh, it's been brilliant to speak to you this afternoon. Thanks so much for joining us.
Absolute
Where
pleasure.
can people find out more about you and your work?
Well, I mean, I'm all over LinkedIn, so you can find me on LinkedIn. I've also got a YouTube channel, so if you want to have a look on my YouTube, The Hormone Effect, and I've got a website which I'll share with you as well, which you're welcome. But if anyone wants to reach out and talk to me more, I'm always happy to have a coffee with anybody.
Oh, amazing, Becky. Thanks so much for joining.
My pleasure. Thank you.
Big thanks to Dr. Becky for sharing her insights on the landscape of women's health technology. Here's what I took from our conversation. Becky expanded on my rather lazy suggestion that the patriarchy was probably to blame for the misunderstanding of female physiology and underrepresentation. It's not about blame, it's about trying to move forwards. Becky champions transparency as a way to build trust, all the way from how drugs are tested and who they're tested on to how new digital tools are built and developed. And for a product or service to be useful, the voices of diverse groups of people must be heard, and at every level. I echo Becky's hope that going forwards, more women founders can find funding, and that more products are built with the intention of solving a problem rather than with the intention of making money. Links to Becky's YouTube channel, website and LinkedIn profile are in the notes, and thanks so much for listening.